Good morning, everybody. I'd like to welcome you all in the webinar COVID-19, Biomedical, Social and Legal Aspects. My name is Vicky Chonka and I'd like to welcome you on behalf of the organizer team, the Eötvös Loránd University, the Semmelweis University and the UNICA network. So thank you very much for joining us today. Before we start, I'd like to give you some technical instructions about the event. First, please write your questions always in the chat. Our team will collect them and share them with the speakers. Please don't forget to mention the name of the speaker if you dedicate a question directly to him or her. And also please share your affiliation with us. Please note that the event will be recorded and made available on the UNICA website. After the event, we will send you a brief evaluation and we would like to ask you to share your feedback with us. Thank you very much and enjoy the event. We will begin with the welcome addresses of the rectors of the universities and president of UNICA. So first, I'd like to give the floor to LÁSZLÓ BORHY, rector of Eötvös Loránd University, then to Béla Merkely, rector of Semmelweis University, and then LUCIANO SASO, president of UNICA. Rector BORHY, the floor is yours.
Thank you. Thank you very much. Good morning, dear Rector Béla Merkely, dear President LUCIANO SASO, dear speakers and participants. It's my great pleasure to welcome you at the COVID-19 Biomedical, Social and Legal Aspects webinar organized by Semmelweis University, UNICA and Eötvös Loránd University. Since the spring of 2020, due to the COVID-19 pandemic, we have been experiencing enormous challenges, forced to adapt to a very new situation and to overcome difficulties we have never seen before. We all have seen and know very well how the pandemic has affected the higher education sector all over the world. This topic has been discussed several times from different perspectives, and we have shared our best practices and tried to help each other in many ways. For example, through the channels provided by university networks like UNICA. However, the responsibility of higher education sector and particularly the universities is not only to reflect on the consequences which directly affects us, but to explore, analyze and make visible all the diverse effects and, most importantly, possible solutions to the challenges caused by COVID-19 worldwide. The spread of the COVID-19 disease has affected all spheres of our life. This online event today gives us the chance to discover and discuss these effects, the biomedical, social and legal aspects of the pandemic with presentations by distinguished experts from member universities of UNICA. Looking at the promising program of the webinar, I do believe that this event will make very valuable contributions to the knowledge and experience we have on the COVID-19 disease and the epidemic. It is a great honor and pleasure for us that our speakers have accepted our request and can participate at today's event. I very much look forward to meeting and welcoming you again in person, but until then, I would like to thank you once again for joining this online event and to wish you interesting presentations and very fruitful discussions. Thank you very much for your kind attention.
Thank you very much, Rector BORHY. And now I'd like to give the floor to Rector Merkely. The floor is yours.
Thank you very much. Dear President SASO, dear Rector BORHY, dear participant, on behalf of the Semmelweis community, please allow me to greet all of you on the occasion of this international event. Through its outstanding activity, UNICA has contributed to strengthening the European higher education area, as well as enhancing its feasibility for the past 30 years. For this reason, it is a pleasure that we, Semmelweis University, are a member of the organization. The present webinar's topicality is unquestionable now that the world is facing the second wave of coronavirus epidemic. We consider this UNICA event an excellent initiative as it approaches the challenges caused by the pandemic in European countries from different aspects, biomedical, social, and legal regards alike. Here at Semmelweis University, in addition to the challenges caused by the epidemic, we have also been provided with an opportunity to reconsider our strategic concept. The virus and the new situation that it created has directly affected all three pillars of Semmelweis University's mission: education, research, and patient care. As a leading biomedical university, we have dynamically accepted our activity to the novel situation, adapted. And we can say that we have been successful in managing the difficulties. Today, the focus will be on the clinical field, and we will present the activity of Semmelweis University in the area of patient care. The pandemic has created a serious challenge, but also a noble task for our community. As a leading biomedical institution, Semmelweis University has been playing a major role in handling the pandemic situation in Hungary. Our leading professionals have set an example in both implementing high-quality online education and organizing patient care, which will be presented by my esteemed colleagues during the webinar. Finally, I would like to thank you once again to President Luciano SASO and his team for organizing this event, and I'm confident that we will all gain much useful information by the end of the day.
Thank you very much to both rectors. A very warm welcome from me as well. I'm Luciano SASO, President of UNICA. This event is really very interesting and very important for UNICA in this tragic moment of COVID-19. Many people are suffering, and for universities also it has been a very difficult moment. But UNICA is trying to react in a good way to this crisis. And actually, we started many new activities which before were more difficult. We organized already several webinars, and we are planning others. So in a way, I think we should try to face this difficult situation in a positive way, using also the opportunities that the digital push is allowing us. And I want to say that it's very pleasant for me to see two UNICA members in the same city to work together. This is something that we always try to encourage, and we know that it is a little bit more difficult to work together when you need to have different teams, aligning the different programs, etc. But I have to say that the final program is really excellent. I'm looking forward to listening to so many interesting presentations today. Just a couple of words about UNICA, maybe for the participants who do not know our network. UNICA is an association of 53 universities based in 37 capital cities of Europe. Europe, that is not only European Union, but we are very proud to have several countries not belonging to European Union represented in UNICA. And we actually organize activities, events, projects, around internationalization and on topics which UNICA members feel important for them. So our motto is to share actually good practices, and this is the main idea of UNICA, to try to learn from each other. And I have to say, in the last 15 years working in UNICA, I learned really a lot. So I want to thank very much the two rectors, LÁSZLÓ BORHY and Béla Merkely, for this, for taking this initiative. Their international offices. I want to thank very much Marcel Pop, the director of the Directorate of International Relations of Semmelweis University, and his collaborator, Diana Modos. I want to thank Ferenc Tako, the head of office of the International Strategy Office of ELTE, and Katalin Igaz-Oller. Of course, the UNICA office did a lot of work for this event, Victoria Chonka and Laura Colò. And I want to thank all the speakers who accepted our invitation, the chairs, Attila SZABÓ, Vice-Rector for Clinical Affairs at Semmelweis, and Eva Oros, who is a professor and the head of the doctoral program in social policy at the ELTE University. Special welcome to Eva. We have been in touch in the past for other activities. I'm very happy that she is active again in UNICA activities. I want to thank all participants for being with us today. And I want to say also finally that this we can call it a Budapest day for UNICA, because we have this great event in the morning, and then in the afternoon we have another important event, which is the University PR and Communication event, annual event. And the title, unfortunately, this year is very significant, because we gave a title, University PR and Communication from Behind the Mask. And this event is organized by ELTE. And so I invite some of you maybe to stay online in the afternoon and to listen also to the presentation of the afternoon. So without further ado, I would like to give back the floor to the rector, Béla Merkely. In this case, I would say that is more significant his affiliation as a head of the Clinical Epidemiology Analysis Working Group of Semmelweis University, because he will give a keynote speech on novel coronavirus epidemic in the Hungarian population, a cross-sectional nationwide survey to support the exit policy in Hungary. Please, Professor Merkely.
Thank you very much for giving me the opportunity to present the COVID-19 pandemic story in Hungary, and also giving me the chance to present the Hungarian coronavirus disease 19 epidemiological research, which is a nationwide representative epidemiologic survey which was carried out in the middle of May. Let me speak on behalf of the Clinical Epidemiologic Analysis Working Group, which consists experts from all of our medical university, from Debrecen, Pécs, and Szeged, and of course from Semmelweis University. So let me quote my colleagues. So medical universities are the sentinels of the nation, especially in this very significant and critical situation in which we are. Let's see, go. Okay, if you look at this figure, this clearly shows you the spread of the COVID-19 pandemic, which is still high. In the US, the pandemic reached a plateau phase. In Europe and Southeast Asia, the number of new cases is still increasing. So we have over 36 million active cases. And of course, unfortunately, we do have a lot of deaths due to the COVID-19 pandemic. Let me speak about the major characteristic of the epidemic, which is the reproduction number. The reproduction number R is extremely important, and that's why we try to estimate the R value. And this figure shows you the R parameters during the whole pandemic in Hungary, demonstrating the different situation during the last half year. If R more than 1, which means that one infected person plagues in general more than one person, if R is equal to 1, which means that one infected person plagues in general one further person, and if R less than 1, which means that one infected person plagues in general less than further one person. And there are different situations, and you can clearly see on this figure, which demonstrating the R value during the whole pandemic in Hungary. We have epidemic situations. Sometimes we achieve a plateau, we stagnate, and if it's going down, this is the case of eradication. The R value depending very much on daily contact numbers, the probability of transmission of the infection, the proportion of the responsivity in population, and the length of the virulent period. If we go back in the history, the first patient was confirmed on the 4th of March, which was actually a Semmelweis international medical student. So after 12 days, Hungary decided to close the country, and there was a huge restriction, because in that specific situation, there was no other way to control the epidemic. We had to significantly decrease the interaction, the social interaction among the people in Hungary. So our goal was to reduce by 62%. And we were very, very successful, because our nation accepted this restrictive task. This figure demonstrating Hungary's first and second wave of COVID-19 pandemic. This figure shows you the daily reported cases and the 7-day moving average. And I would like to also raise the attention that our Hunkever 2 weeks nationwide representative screening was carried out between the 1st and 16th of May, and that gives us very important, valuable information about the first first wave of COVID-19 pandemic. But if you compare, of course, the first wave and the second, you can clearly see that there's huge difference. But if you see this very long period between the middle of May up to end of August, we have a very, very quiet and special, unique situation in Europe, because the rate of confirmed cases was less than 10 in general during the whole summer, and it was very good for just having a little bit rest during the 2 wave of COVID-19 pandemic. Let me show you some interesting data which is coming out from the results of the 4 medical universities. The confirmed cases number are very much depending on the rate of screening and testing. So if we intensify the testing, we will have much more positive results. So that's why the rate of positivity plays a very important role in determining the pandemic situation. So it's also important just to make differences among the population. So we do have patients with symptoms. They are the symptomatic patients. We have contacts. They are the contacts to the symptomatic patient. And we also have so-called patients who do not suffer from any symptoms, and on the other hand, they are not contact. We can call them the quasi-representative patient population, which is, of course, not exactly the same, but we can calculate with that number also. And this, the so-called all screening test positivity is also important. So if you go back to symptomatic patient, you will see that during the first wave, it was around 5%. And nowadays, during the second wave of pandemic, it is around 25. It's at least 5 times higher. And if you look at the contacts, it is clearly around 8 to 9%. compare the previous 4 or 5%. And if you look at the so-called quasi-representative screening among the cases who are not suffering from any symptoms, they are up to 4%, which is also very high. And if you look at the all test screening positivity, it went up to 10 to 12, sometimes up to 16%, which demonstrating an active pandemic situation at the moment. So go back to the history, go back to at the end of April, in which we had actually not enough information to decide what to do, so whether we can exit from the restrictive situation. So the only introduced restriction seemed to be very effective. Mass infection did not occur. We had some nosocomial infection, mostly in nursery and of course in some hospitals. The PCR results showed low infection rate. So the question whether we could start lifting the restriction, but there is a need for clear data. So that's why Semmelweis University, University of Debrecen, Pécs and Szeged decided to organize a nationwide representative screening with the very strong collaboration of the Central Statistical Office and with the support of the Ministry of Innovation and Technology. Our goal was to get an objective cross-sectional image about the spread of the virus, the dynamic and the real number of those infected or having been infected with the novel coronavirus through a representative nationwide clinical epidemiological survey. So what does it mean, representative sample? Each individual in the population had an equal chance of getting into the sample, and each individual in the sample representing a previous determined part of population, so probably one sample, one special person represent 500 up to 1,500, depending on the situation. So the participation, the high participation rate is extremely important to get a good result. The result of age uncover were representative in countrywide, regional and age group distribution. So they could provide a reliable estimation about the country's contamination and seroprevalence. So we divided Hungary into 4 parts. All university had its own region. The target population was 14 individuals, above 14 years old, individuals living in private household. 2-stage stratified probability sample were carried out. We were selected settlements as a primary sampling unit, and the first stage at individuals at the second stage. Altogether, almost 490 settlements were selected. The district of Budapest and all larger settlements were including, in which at least 5 cases were reported and other stratification methods were taken into account. The selection of individuals were within the settlement, and individuals were selected by systemic random sampling after ordering them by age. And the total number of sample size, assuming 10% sampling, frame error, and 70% participation rate, 17,000, almost 800 individuals were selected. So if you look at this flowchart demonstrating the situation, what was done, the total population from this 10 million, 8.283,810 person was represented by 17,787 person. We were able to contact by a mail in 17,787, as all patients were actually directly contacted. with via client gateway 7,300 and telephone 14,250, which was extremely important just to give them the information that they were selected for this nationwide randomized study. The frame error was around 2,300. The patient who died, who lives abroad or in an institution or without information. The refusal of taking part in the surveys included 3,100 persons. We selected, we were able to get the answer for questionnaires via online, telephone, and with the help of the universities. The total participants for biological sampling was 10,575. It was a very big effort from all of the universities. 384 fixed screening posts, 5 screening buses, 1,152 persons screened in their homes. We included 1,245 co-workers from 4 universities and almost 400 volunteers with the help of the National Ambulance Service and the lifeguards of West Spring. If you look at the results, we were able to get 12,236 questionnaires, 10,555 with biological sampling. And if we collected all of the important information, 10,474 persons had biological sample plus questionnaire. The attendance rate was extremely high if you compare with other studies which was published at this period of the year. It was 67.7%, and it was a little bit different in the 19 counties, between 75% up to 59%. But we were extremely satisfied with the result, which demonstrated a very good response for our public. So go back a little bit in the history, so just to compare with the data which was available about the confirmed cases. So the confirmed cases which was actually tested from the 4th of March up to the 16th of May, there were 2,580 positive confirmed cases in private household, and 884 included women and men in institution and nurseries. So that means these 2,580 represent something which is difficult, because these strategy, we did have much more screening and testing in central Hungary, and much less in the other region in Transdanubia and northern Hungary. So the majority of the positive cases were actually in Budapest, and that's why we did not have a real map for us how actually is the situation in a different region, because the test and screening strategy was different in the different region. But if you look at this confirmed case group, in that it was quite interesting. We had much more older patients than we expected. So if we go to the results, it was quite interesting. After having 50 days restriction, only 3 PCR positive cases were found among 10,575. 2 of them were hospitalized, and 1 was actually symptom-free. 70 seropositive cases were found, and if we try to compare the total study population, the positivity, the positive patient were a little bit older than this total study population. So if it was a very special representative patient population in different regions, so we can calculate the prevalence for PCR positivity, which was 2.9 per 10,000 with a confidence interval between 0 to 6.7. And from that, the estimated total number at this period of the pandemic, which was 2,400. And the estimated total number was 56,400 because the prevalence after having the calculation came out for 68 per 10,000. So what does it mean? If we go back to the formal picture, you can see that we had 2,580 confirmed cases, and we estimated the total seropositive patient up to 56,400, which has around 0.7% prevalence, 70 per 10 million. So that means at least 21 times more seropositive cases that were confirmed with PCR test. We had more patient among pensioners and more patient among and less patient about among who are not working. We also had some results from our questionnaire. Of course, we had much more higher prevalence in the group of having the contact and opportunity and the person who were in quarantine, and more chance to get the virus who had an international travel after March 2020. So we have 3 great regions. So we estimated the contamination and seroprevalence in the great region based on the results of hand cover. In central Hungary, it was 7.9 per 79 per 10,000, and it was 2.9 in general. It was 4.9 if you have the active PCR results. These are the estimated seroprevalence based on the so-called well-known 8 region in which Budapest is separate. So you will see that it is 90.5 per 10,000, and the lowest is 46. So that means there was not too big difference among the region. The maximum difference was the factor 2. So it was much more homogeneous than we were able to calculate from the confirmed cases, which was given actually by our agency. So we also checked the seroprevalence regarding age, and it was interesting that our western part demonstrating younger age, and in eastern part we had more patients with seropositivity who were older. There was no difference among male and female, but it was quite a clear tendency for having older patients among the seroprevalent and among the actually contaminated person per 10,000. We're also demonstrating similar contamination in smoking and non-smoking patient population, and there was no difference regarding body mass index. Of course, we know that the outcome of the infection very much depending on these 2 characteristics. If you look at the comorbidities, infection is consequently more common in case of comorbidities, high blood pressure, heart disease, chronic lung, liver, or kidney disease. And if you look at the symptoms, among the test positive patients, we had much more who suffered from muscle pain, smell and taste disorder, and it was clearly significant. So especially loss of smell or taste was very, very specific for COVID-19. So if you would like to shortly summarize or uncover result, it was the first representative nationwide study in the world using PCR and serological tests to examine contamination and seroprevalence, conducted 50 years after the containment regulation in the course of 2 weeks, well representing the effect of the containment regulation, provide the foundation of the exit strategy. 77% participation, which is outstanding on an international level due to multi-channel communication, direct contacting, and the role of fixed and mobile screening sites played a role achieving that extremely good results. Due to the early restriction, both infection and seroprevalence are low. The rate of PCR confirmed active cases is very low. It's 2.9 per 10,000. It is 0.029%. Their estimated number is 2,400 in that patient population. In that population in Hungary, the number of seroprevalent, seropositive persons measured by immunoassay testing is 0.7%, and their estimated number in our population is 56,000, which is 21 times higher than it was confirmed. Based on region, the highest value in Budapest, 90 per 10,000, the lowest in North Hungary, 45 per 10,000 persons. So there are different exit strategy, and if you look at, we had a very long period without any significant infection. If you look at Romania, Ukraine, Albania, or Bulgaria, after having the first wave, having not enough data, they did their exit strategy. They opened the country, which resulted a significant increase of positive cases during the whole summer. But unfortunately, Hungary, after having a long period, mostly due to the tourists, which were Hungarian tourists who visited Croatia, having the chance to be infected, around 220,000 Hungarians went to the Croatian beaches. They were able to reinfect our nation, and this very long period was only enough until the Hungarian went out, crossed the border, and brought the virus back to Hungary. So if you look at the results of the second wave, 14 days cumulative case number demonstrating that in Hungary we had much more patients, so we are closer to the highest rate of infection in Europe. And if you look at the situation, we have to take into account not only the confirmed cases, but also the test per thousand, because they can also influence the positive numbers. And it's also important to know what about the positivity, what about the rate of positive cases, which are different from country to country. So it seems to be, if you compare Austria, Czech Republic, Hungary, nowadays, it seems to be that the worst situation is in Czech Republic, but it seems to be that in Austria, they have in nationwide a relatively less patients than in Hungary. So if you look at weekly, the whole situation in Hungary, you can see that after having a small first wave, there was an absolutely quiet situation. with an average of 4 to 6 confirmed cases per week, and it went out up to 1,000 per week during our last week. And these are the confirmed cases during the whole pandemic, demonstrating a significantly large patient population. What about the role of medical school? So we started with our PCR test via the green columns, and we played a more and more major role just to demonstrating the 4 active universities. In Hungary, there are over 100 hospitals, but the 4 university departments contribute to this testing extremely well. Of course, confirmed cases and seropositivity are important, demonstrating the pandemic situation. But I think it's also quite important, what about the mortality ratio in the European countries? The mortality per 1 million inhabitants demonstrating on that figure. And you can see that Belgium, Spain, UK, Italy, Sweden, France, Netherlands, and the Balkan region demonstrating the highest mortality. In the middle, Switzerland, Luxembourg, Portugal, Israel, Russia, Albania, Germany. But there is a significant fraction under 100 per 1 million, including Belarus, Hungary, Austria, Serbia, Czech Republic, Slovenia, Croatia, Poland, Finland, Norway. But it's very difficult to keep the mortality under 100. So it seems to be that this number will increase. So what about the future plans? 2 more cross-sectional studies are planned until the 1st of May 2021, which will have an interface of 1,500 persons with the population of the first sampling. Before nationwide vaccination, we will survey the current contamination and seropositivity rate in order to assess the severity of the second wave. And I would like to also use the opportunity to thank for support of the participating inhabitants, majors, National Ambulance Service, Police Force, Water Rescue Service, national and local media, and our Ministry of Innovation and Technology. I would like to also raise the attention that the biweekly change in confirmed COVID-19 case in countries showing the greatest incidence in some countries in Europe, especially if you look at this columns, and in which Hungary, unfortunately, in the first third in the second wave. So if you try to show you European mix, you see different scenarios in Europe demonstrating the 2-phase, or without having 2-phase, like Romania and Bulgaria. They have only 1, but they seems to be constant. So in the countries in which we have significantly less patients in the first wave, we have much higher chance to get a larger second wave, because the population does not have bad experience. This is not the case in Italy, because Italy had a very strong pandemic, and they have, of course, very bad experience with the virus, and that's why you are able to keep the number relatively low. This is not the case in Central Europe, because we were very, very successful in preventing a high number of COVID-19 in the first phase. So these curves demonstrating the activity in different countries up to end of September, and Romania, Poland, and Slovakia moving average again, showing an increase. In Czech Republic seem to be some positive changes. In Croatia, decreasing trend, and Austria and Hungary, they are very close together. They have a relatively stable number, but an increasing mortality. This map's helping us just to have a look at what's happening in Europe, demonstrating the incidence and the specific incidence. This figure shows you where has the risk of the spreading of COVID-19 increased, and there are countries with wide areas and certain countries which include also Hungary at the moment. But Hungary is a small country, but there are also a lot of difference even within the countries in Hungary. And some differences between the first and second wave. If you look at the second wave, we have much more patient red columns between 15 and 24. And it is changing slowly, and the number of older patients are increasing. Just have a look at the blue columns, which demonstrating step by step more and more patients. These figures show you the so-called weekly average, the mean value of the age, and after the end of summer, in which we had around 30, it's increased by 14 years. So nowadays this is 44. And if you look at the change between the 36 and 39 years, you can see that the number of diseases or confirmed cases are slightly decreasing in younger patient population and steadily increasing in older patients, which contributing in a higher mortality rate. And this is very important just to look around what's happened in the past. This is the case in Florida, because a great risk of increasing spreading of the virus among the youth, and with the time it can also reach every age group, mostly elderly. So after having the increase in the number in the daily cases, the increase in the number of deaths showed a 5-week delay. So if we have more patients at the end, we will have much more mortality. But we do have some positive changes in the lethality, the so-called age-specific COVID-19 lethality, which is significantly lower. It could contribute due to the higher testing activity from one side, but of course we had much more experience in treating patients with COVID-19. So we have to survive, of course, the next 6 months. Probably we have to organize our life in another way, which was quite pleasant for us before. So that's why we have to reorganize our everyday activity. And from nationwide, we have to extend the PCR screening and also increase the screening in patients with higher infection risks without any symptoms, and in those affected through their professions. The wearing of masks should be achieved up to 80% at least, and the social distancing and hand hygiene is also extremely important. We have to face actually another important issue, and that's the schools. So what kind of contact reducing strategy can be considered in the school? And this is our everyday practice. The most common situation, even in our university, that our doctors and nurses are infected through their children. So that's why we have to take into account that we should reduce the risky close contacts in the classroom. The wearing mask during the classes is also as important that between. And we have to also reduce the risky close contacts between the classes. Another important issue, an authentic and convincing risk communication based on professional expertise continues. This is extremely crucial. Instead of fear and passivity, building on awareness raising, the involvement of the public, much more important. Emphasizing that no one is to be blamed for the spreading of the virus. And we have to address to the youth, they are much need in the protection, and we should build on them. We should explain the risk, shifting emphasis towards individual and communal responsibility, protecting ourselves and others. So let's work together, and I really appreciate the opportunity to present the Hungarian situation and the uncover nationwide representative study in this UNICA web seminar. Thank you very much for your attention.
So thank you very much to Professor Merkely for this excellent presentation. I think the data will be very useful for all countries represented in UNICA and beyond. So we will post this presentation online, and I'm sure that again this will be a document that will be used very often by UNICA members. So as you know, there will be no questions after this keynote. So at this moment, I would like to thank again Professor Merkely and give the floor to the moderator of the next session. The next session is on biomedical aspects.